YouTube Live on, what are we at, John? April the 10th, I believe. Is that
April
correct?
10th,
I nailed it.
right.
I nailed it. This is Through a Therapist's Eyes. I am your host, and we have a special person with us today. This is Carrie Hill. She is the bestest medication management person like ever, Carrie. I'm so excited that she's in town.
Thank you for having me. I appreciate
Yes. So, and John is hanging out with us as well. We've lost Victoria this week, I guess. She had her seat replaced. Is that what happened?
That's right. But she's doing great here.
Yeah, we're covered.
We're covered.
We are
right.
covered. If this is the first time you're finding us on this platform, we do a YouTube Live on Thursdays about 6:15 to 6:30. It's a great way to catch up with us live while we're doing the show. We can incorporate you in. We love to interact. Otherwise, here in a moment, we'll kind of kick on the mics live for what you hear on Spotify and Apple Podcasts and all this kind of stuff. So,
Podkicker.
And you have taught us about Podkicker.
Right.
I didn't know it even existed.
It does.
Seems
And they
like
always want to charge you.
Oh, they do? Are we
Yeah.
being charged, Neil? No, he says no. We're not being charged.
Yeah. So you don't have commercials on Podkicker.
Oh, they want to charge you, the listener, not
Right.
me or you,
Right.
the...
No, not you guys.
You're the podcaster. You're the listener or the
Right.
podcaster? I
The
guess.
listener, because I use that to listen to, and it's very good.
Podkicker.
Yes.
Are we getting advertisement for them?
I don't think so.
Then we should stop talking about Podkicker.
Okay.
They need to pay us for that, John. All right, we're ready, Neil, when you're ready to go live. Yep. Hello, this is Through a Therapist's Eyes on April the 10th, 2025. I am Chris Gazdick, and as usual, we have Mr. John Pope hanging out
It
with
is
us
a
today.
pleasure and an honor to be here.
All right, man. But we got somebody else that's hanging out with
Yes.
us today. Yeah.
Absolutely.
Very excited.
It's a stranger.
It's not anymore.
Not anymore.
She
No,
is-
every time you sit, yeah.
She is a part of Gaston County now. She is
Right.
She is a local medication prescriber. Welcome, Miss Carrie Hill, to the show.
Thank you. I appreciate it. Thank you for having me.
We're very excited about this particular episode because we don't get to talk about medication management a lot, and it's a big part of our field. And
It is, and it's
Yeah.
something I think we should address
probably more. Yeah.
more. Yeah.
There's a lot of things we should probably address more, I guess. But yeah, and I'm excited personally, Carrie, because I just, on my career, like I've always been around prescribers, usually psychiatrists and stuff. Like I even had experiences at the UNC Neurosciences in Chapel Hill, is where I had like my first real job as an adult after school. And so I was with psychiatrists in training even at the Neurosciences Learning Hospital up there. So I haven't been working around psychiatrists or prescribers in how long has Metrolina been here? For 15 years for sure.
Right.
No,
definitely.
we had Carol here. So
Yeah.
even then I've had her for a little bit. But I'm anxious to hear the newest pieces of prescribing these days.
Oh, there's a lot of changes, a lot of new things going on and new medications.
Yeah, well, and that's one of my questions I want to talk about is new medications because I am out of touch. But nevertheless, we are talking about medication management today with Carrie Hill.
Do you want to say any? We're not.
Oh, I will. Yeah,
okay,
we'll do
good.
introductions
All right,
and stuff
good.
for sure. And so the three questions as we go through the show that I want you to think about is, have you ever considered how medications might play a role in your mental health treatment plan? Secondly, what concerns or questions do you have about starting or managing psychiatric medications? Because people have concerns. And then how do you currently monitor and assess the effectiveness of any mental health treatments you're undergoing? And that's kind of just a interesting thing about medications. It's kind of easier to do that with. But thank you, the listeners, to you specifically. Thank you for listening. And you followed up, John, not more than an hour after our show last time. We have another new YouTube member.
Yay.
Let's welcome them in. Shane Jones, welcome
Hey,
to
Shane.
the Through a Therapist's Eyes Tate experience on YouTube Live. So we have Neil. What are we up to? Do you know? We're pushing. Oh, I thought it might have been 221. Okay, so we're on our way to where we want to be, which is like 1,000. So we'll keep building that. Let me see. This is the delivery of therapy services, John, or is not?
Is not.
It is not.
No, we have these topics we talk about, but
We're not doing therapy today. Not right now
You
online.
do therapy, you have to have you need to talk to someone.
But this is where you get information about mental health in your car
So
or
it's
personal time at
educational.
home, and entertainment. Anyway, what else is part of my normal spiel, John?
And you give a 5-star review.
Okay, if you
that's
wanna.
my spiel. And so and you can comment on it and just give us some glowing positive reviews.
Your job is to do what John asks. 5 stars, not 4 stars. If you like the show and the
5
content that we
stars,
give
yes.
you for free. So this is the human emotional experience which we endeavor to figure out together. So Carrie Hill is you're gonna have to explain all these letters first of all.
Oh yeah.
I don't even know all these letters. Like these are a
I
lot
know
of
what
letters
AP
behind her
is.
name,
So
John.
who did all the research?
This is Carrie, pmhnp.bc, CARN.AP, a board certified psychiatric mental health nurse practitioner and a certified addictions registered nurse with over the 16 years of experience. So, seriously.
In psychiatry.
Yes.
In
Psychiatric nursing.
Psychiatry. Seriously, welcome to the show, Carrie. I'm
Thank you.
very
Thank
excited
you.
to
Thank you
have
for
you have
having
this
me.
conversation. Tell us a little bit about yourself. What are the letters, seriously, and a little bit about Carrie, who you are, where you come from, what you do, what you like.
Well, I have been in the Gaston County area since 1990s. For a
Oh,
long
wow.
time now. I was actually born and raised in Charlotte, and I have been to quite a few schools in all over North Carolina. I started at Gaston College and got my 2-year degree, my associate's degree in psychology, but I didn't really know what to do with it. And then I thought, well, I don't know what I want to do, what my path is. So I decided to go to Belmont Abbey College and get my computer science degree.
Instead of medication and nursing. Okay.
Because I didn't know what to do. I was kind of lost,
John,
just
this
kind
means
of
she's
out
been
there.
in school like as long as you have.
Yes.
Yeah.
I like school, but I'm done with it now.
Okay, we're done. Good.
Yeah, this is it. So, and then after Belmont Abbey, I decided that I didn't really want to sit in a cubicle and work on computers. Although I love computers, I do not want to be in a little, it has come full circle though, and I'll tell you about that. So then I went back to Gaston College, second time, and got my registered nurse from Gaston College. Then I went to Appalachian
You
State
really have been to like every
University.
school in the
So
state.
You're a mountaineer, huh? You're a mountaineer.
I'm a lot.
She
I'm a
is
lot
a
of
baby
things.
mountaineer, John. I got to be honest with you. I got to correct you. And it drives me nuts when people try to call Appalachian State mountaineers. Like, I
Okay.
am a mountaineer, okay?
Okay.
West, by God, Virginia
Oh, my
University
goodness.
mountaineer, Carrie.
Look,
I'm so sorry
you're
for this.
in North Carolina now.
You know what, ma'am? I'm sorry. We are should we just move on?
Yes.
Yes.
Okay, we
Yeah,
So
let's move
then,
on.
after I got my bachelor's, I went to University of North Carolina, Chapel Hill, and got my master's degree. And so the PMHNP BC is the Psychiatric Mental Health Nurse Practitioner board certified. So I went to school specifically for psychiatry. I did not go. There was no route taken for medical. I wasn't interested in anything.
You
but
knew what you wanted to do.
I knew immediately that what I wanted to do. Although a lot of my, when I was in school, a lot of the nurses and the teachers would say, you really need to do medical first. But I was not interested in that. I had seen enough in my clinical rotations, and I had done enough learning throughout my school to know that, no, it's not my thing.
Gotcha.
So, and then about 5 or 6 years ago, I started doing addiction treatment. And so the CARNP,
Carn.
the CARN AP is a certified addiction registered nurse, advanced practice. So that means that I went back and got a certification specifically for addiction treatment because I enjoy taking care of clients that have, problems with both mental health and substance use issues.
Right. What's that, John? You had a
No,
thought?
I was just in awe. I think it's wonderful that
Right, because you know as well as I do, right?
Right.
How valuable is a prescriber who knows anything about substance abuse?
Right.
Right. Unicorn sitting with us.
Yes.
Yeah, seriously. I mean that as a compliment. Really, that is super, super cool.
Or even in other psychiatric areas as well. I mean,
yeah.
so
There's still such a great divide in our field where you work with mental health and you refer out for substance abuse, or you work with substance abuse and you refer out for mental health. And it drives me crazy. Anyone listening to this show, I'm sorry if I'm stepping on toes or upsetting anybody, but really, we all need to have substance abuse training, is my staunch belief, because it creates such a blind spot when you don't know what you're doing with that. And my gosh, Carrie, can you imagine all of the addicted individuals that are getting prescriptions for all sorts of things, and the prescribers don't have any idea that that's what's going on?
That's exactly right.
Again,
and
I could just
a lot
rant.
of times, if people aren't trained specifically on what to look for, they might be trying to help a problem that somebody came in for originally, but it was stemming from the substance use, and because that client doesn't feel comfortable enough talking about it, or was never really asked the questions regarding that, then they don't know what
You're
they're really doing.
preaching to the choir.
Yeah.
This is absolutely
Simply ask the
essential.
questions.
Simply ask the questions.
Yeah.
Right. So I really enjoy what I do, and it's my passion. And addiction is it's not only drugs. This is all kinds of addiction. This is food addiction. This is, even caffeine can be an addiction. There's all kinds of things. It does not have to be
Don't
just
step on my toes.
caffeine's always been my in food. But yes, there's a lot of other and behavioral addictions. A lot of people don't realize that, a lot of people after work want to come home and they want to get on their phone or whatever and zone out. And that's fine to disconnect from whatever for a while, but you shouldn't, be sitting there for 5-6 hours and
Screen time.
right.
Yeah.
So a lot of things can be
Yeah, so you're talking in terms of process addictions, gambling. You're talking
Right.
about the internet addiction, porn addiction.
exactly. Yeah, because all those
Sex
things
addiction.
can cause problems in relationships, and and end up in lots of trouble sometimes with the law on the latter too. So
Right.
yeah.
Cool. So let me jump in with what is your philosophy? I mean, there's some stuff that you've got on the Insight or in the internet sites and such, and Road to Recovery is well. Let's first cover how do people find you?
Oh, they can either search my name, so Carrie Hill, and then all those letters.
Yeah, right. Don't try to put all those letters in.
So-
Just Carrie Hill will do plenty.
The Underwood comes up.
Yeah, I know.
Carrie will come up as Underwood, but that's not the right one. Thank you, John.
Yeah.
Now what's the website and where do they find you?
Oh, so my website or the name of my company is Road Trip to Recovery. So it's road trip 2 with a 2 recovery.com. And the way I approach treatment is very holistically. I like to look at the patient as a whole. It's not just about what symptoms they came in with. It's about what is going on in their life, what may have, led up to what's going on, the social aspects, sometimes the spiritual aspects of things. Sometimes, people don't know where they're headed or going in life. They feel a little.
Sorry.
Yeah.
Rookie mistake. My phone
Okay.
just went off.
Yeah.
That's okay. And then, of course, all the medical background and all the mental health background. I am very good about keeping up with what medications people have been on and what they've tried and how they reacted to it, and what, if they had side effects, because I never want to put anybody back on something they've already tried. So I keep a really good records.
Yeah. I'm going to have a bunch of questions. So
That's cool, John.
I just
That
don't
is
want
what we
to. I
do.
don't want to step on your. On,
No, you're
on
fine.
your
Jump
toes.
in anytime you need
Okay.
to.
Question is that one of the issues that I've seen with some of my clients that are on medication, SSRIs or SNRIs or whatever, they don't take it long enough for a length of time, or they take it sporadically.
Yes.
And I'm just wondering why that is important. That the patient or the client is consistent in taking it.
So that's an awesome little segue, John. Let's finish up with first.
See,
real
I
quick.
told you.
No, you're fine. You're totally fine. I just want to say, like, our show notes, we have totally the links up and how to find Carrie. We'll review that at the end of the show kind of as well. And really, I mean, if you're local here, they can actually be able to soon, I think, have an office, but you do a lot of virtual stuff as well, which is the way we do everything nowadays. But you're also, I wanted to make sure and get in, like, you're kind of different as well in that you're licensed in multiple states and whatnot. Is that, like, how does that work for you? Like, I was shocked at that, like, when that was the case. So how does that work for you?
So I am licensed, my home state, of course, in North Carolina, and eventually I will have an office in either Belmont or Mount Holly. We're working on those things, but virtual care still 24/7 right now. So, but I am licensed in 18 states, and
Oh my goodness.
Right, John.
Yeah, but see, that's the thing is that I'm thinking your practice, your profession, they're a lot further ahead than social work or counseling.
Fair.
And that is because we don't really have portability.
Right.
And I think you probably have portability, don't you?
Well, and it's interesting because I've talked to some psychologists and found out about the psych pack because I didn't know that was something that they had been working on. And it does need to be for therapists and, counselors, social workers for nurse practitioners and mental health. And it needs to be where we don't have to worry about these state lines. And it would be nice one day to not have all these hoops to jump through, but some states I have to get an RN license and an NP license in.
And this is just so important. So you listening public, which by the way, if you would give us a specific list of those 18, because our show does go to all sorts of states and actually countries, but I want to get those exact states that you're licensed in, and so we can put it, get that to Neil and I, so we can have that noted, so people can know which specific states they are. And I'm not even going to try to ask you to repeat them all, but
I was going to say, there's so many I don't think I could.
Yeah, but look at that. Would you get us that information? Because that would be very helpful. And then, John, to your transition, let's talk a little bit about the nuts and bolts here. Like, right? Like, what happens underneath the hood with medication management and stuff? And there's lots of aspects to this about people's fears and how it operates, how it works. You're bringing up some specific stuff about, being consistent, but some you don't need to be consistent with, like, some of the benzos or the anxiety agents or sleep agents or, over the off-label kind of purposes for
You're
things,
right about
right? So
that.
there's a lot.
I'm amazed at how many of my clients are on benzos when they probably don't need to be on
Right,
them. And
right.
So,
100%.
Yeah.
So, Carrie, how do you manage all that? Like, I'm sure people... we have different classifications of drugs. We have different, medications for anxiety, for norepinephrine, for dopamine, for serotonin, for sleep. I don't know if we're doing much for GABA, but like, how do you address John's sort of question and a lot of the depthiness that I'm sure clients, are having?
Yeah, and I always tell my patients I want them to know as much as we can. Of course, we can't tell them everything because there's going to be 1,000 side effects listed. That does not mean that they're going to get all of them, but I always tell them the most important ones that they need to know. And I tell them, I'm going to tell you the good, the bad, the ugly. You need to know what a medicine is going to do, what it's not supposed to do, and what the side effects are, because the more knowledge that they have about what to expect is easier for them to understand what is the medication, and what do I need to, immediately notify about versus what do I just need to, tell her the next time I see her. But so with SSRIs specifically and SNRIs, we use those for depression.
And those are
and
serotonin
anxiety.
reuptake inhibitors.
Yes, and norepinephrine on the SNR side.
Selective serotonin reuptake inhibitors.
SS.
Sorry. To be formal.
So when somebody comes in with depression and anxiety, it's typically because they're not producing enough serotonin. We already have serotonin in our body, and so we need a little bit more to try to combat those symptoms. And you as therapists, sometimes you will get the client first, and they want to come in and they want to work on these things because they don't want to do medication, which is perfectly fine. But after you've been with them for a while, therapy has been good, but they're still not progressing. Then sometimes y'all will recommend, potentially seeing somebody if you feel like it's a fit.
Oh yeah, like all the time.
Good point is that it's when medication done with psychotherapy, effective psychotherapy, the kind that Chris does,
And you.
and me, and Victoria, is that it is a lot more effective, and it makes progress go a lot faster because you can, and it's more permanent. I think. In terms
Well, yeah,
of-
I think what you guys are touching on, I mean, I've talked about it on the show, what I call, Carrie, an overview of mental health with a subtitle, A Tale of Two Tapes. And you've got, almost like a formulaic way of thinking about somebody's trouble, with mental health is what I look at the biological component on one side, genetics, biological, exercise, eating as well. But then you got the other side of the equation, social and emotional realities in life, the primary relationships that you have, the primary life experiences, the daily stress and the grind. Like there's this dynamic combination, maybe it's 60-40, 80-20, 70-30, whatever, but you have to treat both. So I've landed on the fact that the statement I've said thousands of times is that medications are an awesome tool to help manage mental health, but they're just not a solution.
Right.
So that's where this combination of therapy and mental,
much more efficacious, I think, effective
Yeah.
is if you have a combination of both. But I can understand a lot of my clients are reluctant to just go into the medications, and because I think part of our culture right now, the atmosphere. But anyway, that's another point.
Yeah, we'll get to that actually.
Yeah.
I want to talk about that. But do you have like a particular, or go ahead, do you have thoughts?
Well, no, we can talk about that later. The political atmosphere has changed things, and
Yeah, I want to talk about some current events here in a little bit for sure. We'll get a little political, guys. Hold back, because it's significant, it's important, and it does hold people out. But there's a lot of reticence anyway. I mean, people are afraid of medications, Carrie. They're terrified.
yes, and I don't blame them because they should be. You need to know what you're getting into because I would never take taking a medication lightly. You need to really know what to expect because these things, they change and they help, but we also know that they can do the opposite. And that's what we don't want them to do is, have the opposite effect. And I always tell my patients, you need to let somebody know who's close to you, whether it be a spouse or whether it be a parent or whether it be whoever you feel is most comfortable that you're taking a medication and they need to be able to look out for symptoms and changes and as well. So not only the person who's taking the medicine, but also somebody else.
So the formula for that is we look for collateral information.
Right.
Let me ask you this: How long is your typical interview with a client or a patient?
You're gonna love this answer, John.
My typical, usually it's 60 minutes. However,
I told you you're gonna love this answer, John.
however, it could be upwards of 90 minutes. It depends on what.
You're wonderful.
I do a lot of screeners at the very beginning, and I cover the PHQ-9, which is what we use. It's a screener that we use for depression. The GAD-7, which is what we use for anxiety.
Oh, you guys aren't going to start geeking out about
Yeah,
your,
I'm
your,
geeking out because
things,
they're
John,
all
are you?
very effective.
John, you guys can't go for a half an hour and talk about all the little screening tools that you love to use
you
and all
don't
the print
use-
No,
jobs
I
that
don't
you do.
use all of them. I
You
use
don't
7
use
of them.
You use Beck,
See, I told you he's going to geek out with you, but he
Yeah.
loves this
or
stuff.
Hamilton, or
I
whatever.
use-
So anyway, just and you use the substance or alcohol use. Like,
Neil, we're losing control.
and that sort of thing.
Well, now for that, I have a clinical, so separate from my screener. So I have 7 screeners and I have 1 clinical history form. And then, of course, the consents that they have to sign in order for me to treat them.
It's just great.
So,
Let me give you some of the background, listener. The John and I sort of glowing is, and I don't intentionally want to sound critical, but it's a problem. I mean, I started out years ago, in the early 90s learning about all this stuff and graduated grad school in 97, and there were psychiatrists that still did therapy. And, it was a totally different functioning at the time in the field, and managed care kind of came in. And John, you could probably speak way louder than I can to the progression that you've seen in your career, because it's gone from like what Carrie you just described was the typical totally went away, and now it's like the initial appointment with a prescriber oftentimes is 20 minutes. And
Maybe.
the follow-up, maybe, John.
Right.
And the follow-up appointments are 5 to 10 minutes. That's what you get your doctor's time.
And the person, and if you get somebody that's a PA or an NP, they aren't specifically trained in psychiatric nursing or being a PA in psychiatry with a specialty for that, and so you don't get the quality of and the depth of questioning. And some of my clients have had a lot of problems with
It's
medications.
horrible.
They get a Stato, for example. I'm mispronouncing it.
Stratera?
Esteto.
Esteto. Oh, Esteto.
Okay. And it caused a whole bunch of horrific. It's a good drug, good medication, but it has to be used correctly, I think. And as a non-medical person, just my experience with that. So I think that's important that somebody is trained specifically to be able to use those medications.
And spends time with
Spend
your client.
time and listens.
This is really, I mean, do you realize how much of a thing that is? I mean, seriously, that might seem just so common to you, but what have you noticed? Yeah,
That's what I hear from my all of a lot
pretty
of
much
my patients.
every man, woman,
Yeah.
and child that sees you.
It's
They say, "Where have you been?"
Sometimes they don't even look up at me, and if you don't look somebody, or if you're not looking at them, how can you tell what's going on physically? Because nonverbal cues tell you a lot of information.
Oh, yeah.
And so it's not just the conversation. It's
You're saying that the clients are saying to you that their previous prescribers didn't look at them.
right.
Is that okay? Yeah.
Like they were in there, like you said, 5 or 10 minutes, and they never looked up from their
They don't wanna be
computer,
anywhere.
or they never looked up from their, if they're still old school and writing things out.
It's so unfortunate. I'm so passionate about mental health care and substance abuse care that it really drives me nuts that is the standard, that's what we've gotten down to. And I can tell you a lot of prescribers don't like that, but it's just such that the way the market goes and the way the finances of practices are and stuff, that's what they feel compelled, because that's where insurance is driving them to. And thus a lot of people in different markets, prescribers won't take insurance for that reason,
That's
because you're
true.
driven by that. And so
Yes.
there are a lot of prescribers won't take insurance, whereas you do. And I respect that a lot, that you're able to traverse that.
Yes, because the insurance companies can be very hard to deal with, and so there's a lot of providers that are cash only, private pay.
I've seen more and more of that recently.
Well, in our area, that's like the standard. That's just what I don't know. I think psychiatrists just basically got together, John, and had like some secret meeting that you and I were not incorporated into. We just about 5 years ago, it was like, boom, that's it, we're done. That's what happened.
Yeah.
Yeah. What do you think of psychologists being prescribers? There are some in some states that do that.
There are?
There are.
I did not know that.
Louisiana, Texas is looking at it. Illinois, Iowa, I think, Idaho,
Really?
Colorado. Yeah.
I
Dang.
think that we need all the help that we can get. So if, psychologists want to go learn just like another certification type thing for prescribing, then, I don't know exactly what that would entail for them. but as long as, the educational piece is there. And also I did want to circle back to when you were saying PAs. Things have changed in the PA world. Now they can get a certification in psychiatry, but before it wasn't there. But they have to do certain things, of course, to meet the requirement to be able to be. But I have had some colleagues
See,
that are
I
PAs.
don't think one rotation necessarily, and I know, and I love PAs. I love them.
Which, by the way, physician assistant students or professionals is what we're talking about.
Right.
Physician assistants.
So, but I don't think one rotation through is enough.
Meaning what their training is.
Yeah, what their training is.
Right. Yeah, there's definitely pitfalls and fallbacks. I mean, I didn't know that it was being considered for psychologists to be prescribers. There's a lot that goes into prescribing. I'm kind of rather shocked by that, to be honest with you. I mean,
And I think in our professions, social work and in clinical mental health counseling, I think it's important that we all take psychopharmacology. In fact,
100%. Yeah.
Yeah.
I feel like I could prescribe because I've been doing this for a long enough time to understand the titration and the tapering. That's medication dosing and all of those.
And that's the thing. For my doctorate, I took three courses.
Yeah.
So
yeah, it's a lot.
I forgot a lot.
Well, there's a lot of information. So
Yeah, so Carrie, I guess what are some of the complicated nature of things? When you look at a personalized treatment or individualized care. These are some buzzwords that we all try to aspire to, and we don't want to just carte blanche people through. I mean, a lot of prescribing offices are cattle. I mean, that's what we were just talking about. It's 5 minutes, cattle in, cattle out. It's terrible.
Oh,
but
yeah.
when you talk about the individualized nature of things, what do you really come across, or what do you see? What are some of the bigger issues that you come across when you're trying to deal with complicated cases and circumstances with people?
Well, it's just a lot of education, because when people come in, when we look at all the medications together, we want to make sure that the medications that they're taking medically or mental health wise aren't causing any symptoms that they might be having. A lot of people will come in, with complaints of being tired all the time. And, a lot of people can't tell, is that depression or is that something that they're already taking, or, it's just very...
Or another medical circumstance.
Right, exactly. So I always ask, when's the last time you had a physical, and, your blood work and everything, because that is so important to know the whole picture. And, when we think about depression and anxiety, we think thyroid first. We want to make sure there's nothing going on with the thyroid. And then we want to look at vitamin levels, and then we want to look at, make sure there's no anemia. I mean, there's so many things that we think of to be sure that's medically,
So you're screening a lot all the time.
Yeah. And I don't do labs myself, but I do have them go see their primary care doctor to do that, and tell them, what I recommend. Most of the time they already have, the general labs anyway for their physicals. But, I definitely want them to make sure that they have their thyroid and their vitamins, vitamin levels and things like that, so we can be sure everything's okay. And then anything specifically that we're looking for.
Yeah, I think that I'm talking about on, you're sophisticated over there, because what I'm thinking about is like just the regular side effects, the different challenges that people have. Because one of the things I try to do some prep with people that I'm referring, so that they hear some spiels that I have that are standard things to talk about. Because as you said earlier, the more they know coming in, the better they're going to feel about taking and even get there, and then have better outcomes as a result. Because of what you said, John, the consistency of taking things. But, you get some people have side effects and other people don't. Mm-hmm. So, the dosages that you might need, I might need more or less, not just because of body weight or size, but because of metabolism and all sorts of things. Like, there's a lot of inexact science about starting doses and where we titrate up to and side effects and how we manage that. I mean, it can get complicated, right?
Be careful with Dr. Google.
Yeah, well, and do you find that too, or more people?
Oh, yes. Yeah. Yes. There was a lot of anxiety, after COVID. And so a lot of people who didn't know what anxiety was, they found out what it was during COVID, which was, good and bad. I mean, it was bad, that the way that things were in that time, but it was good because now those people can understand what people who already had anxiety were going through. So it's been better on that level. But with medications and side effects, especially SSRIs and SNRIs, the top 3 side effects that people will absolutely stop their medication for: number 1, sexual side effects, hands down.
Yeah.
Somebody, if
John,
they have,
you called it. That was John clapping.
If there is a sexual side effect, they will not tell their doctor, and they will stop taking it. And I always tell my patients, you need to tell me, because we can figure something out if this happens. Don't stop taking your medicine until you see me. The second thing.
So you could do like Viagra or something like that, or what is it, Cialis? I'm using the normal term.
Yeah. Well, sometimes it depends, because if the medicine is working very effectively and that's the only side effect that's going on, then yes, we would definitely do something to help with that problem. But if there's another side effect going on with that side effect, and it's not working as well as we want it to, then we probably are going to change that to something else.
I know you're listing 2 other big ones, the top 3, but I mean, this is terrifying for people.
Yes, it is.
Really, and I'm sure you realize that, but I think we forget, being so engaged with this, so commonly and regularly now for however long we've been practicing, a decade plus, you listening out there, like this side effect thing terrifies people. And so I want you to hear this stuff because there are some common things and there are some ways that we manage that. And also there are a lot of people that have no side effects. That's what I mean by this crazy individual care. Like I may have zips in my mind, electrical impulses with some of these medications, or I may have the sexual side effects, or I may have nothing. That's what's wild,
Because everybody's different. Yeah.
Yeah. But you're listening to the what do we got, the top 10, or we just going
top three? How about
top three?
Second two.
The next one's weight gain.
Weight gain, yeah.
And I always tell patients we are not trying to solve these problems and start new ones. That's not the goal of treatment at all. So, and also with the sexual side effects, a lot of prescribers don't tell the patients. They wait until the patient comes back and says something, and it's like, no, you don't want to you don't want to leave that out and scare the patient when they're like, oh my gosh, why am I not interested, or why can I not finish what I started?
My sex drive just went away.
Yeah,
What's
exactly.
The deal?
I recently had somebody who'd been on the same medicine for 5 years and had no clue that was even what was going on.
Oh no.
So yes, I tell everybody, even if they come to me on one from somewhere else, we go back over everything.
Yeah, you also determine if somebody's been on a medication for 20 or 30 years, like the be all end all Prozac, which has been around for a gazillion years. Doesn't it lose some of its efficacy or efficiency for some people?
It can, because our brains are very smart and it can get used to the pattern of the medicine and it can stop working. Some people can go. I think the longest I've seen is probably 20 years. I recently had somebody on Celexa for 15. And so it can last a very, very long time. And some people may be wondering why somebody's staying on a medicine that long. That's individual as well. It's a personal thing. A lot of people, when they start an antidepressant and they see the difference between the way that they feel on it versus being off of it, they don't ever want to go back to feeling the way that they did. And so they'll continue taking their medicine, and that's perfectly fine. But they can always stop it if they want to.
Now, there's a couple of my clients said, well, I don't want to take medication because it'll change who I really am. And how do you respond to that?
Well, that's what we're looking for. We don't want it to change, because when these medications work too good, so if we're treating anxiety,
just to add to that, there's a big concern. A lot of times we hear we're like, I feel all drugged out, I'm all numbed out, I don't feel like myself. There's real specific experiences people have.
Right, and that's right, because we want the anxiety to calm down and we want it to be manageable. We want it to be mild and infrequent. We don't want it to be moderate, severe, or panic. So.
I usually say, and I don't give medical advice, but I usually say the purpose is to make you feel more the way you want to feel, the way that the more authentic you is a result of that medication.
Right. And when sometimes it's usually dose related. Sometimes it can be on the starter doses, but it's usually dose related. If we get it a little too high, and people can say, I feel emotionally numb. I don't feel like I'm having feelings. I can't cry. I get that, sometimes when it's too high, it's appropriate to cry in certain circumstances, but it's not crying every day. That's not typical. So
yeah, we don't want that.
Staying in bed and crying all the time. You don't want that.
Yeah, that's usually the first symptom actually that goes away. Crying spells are typically like within the first week. That's the first thing that starts to subside.
To get better.
Yeah.
Mm-hmm. Yeah. So what's the third?
So
I'm sitting here thinking, it's like, I got the weight and I got the sex, and I'm thinking, I wish we would have played a game, John. Do you know the third?
Yeah, what's the third?
I don't know the third. My guess is sleep.
The third.
That's the only big thing I can come up with is sleep factor, sleep impact. Do you have a guess, John?
It's a little related to that, but not sleep
sort of
specific.
related? I'm wrong. I'm right, but I'm wrong. What does
being that even mean? Just kind of tired, maybe. Is that tired?
So lethargy and energy and whatnot?
Yeah.
Okay.
Fatigue is the biggest thing, yes.
Yeah.
That medications can have side effects of fatigue.
SSRIs, the biggest ones that could potentially, not all of them, but potentially could, is Lexapro and Zoloft. But I dose my Zoloft at night. And Lexapro is typically morning medicine, but if fatigue was a factor, it could be switched to bedtime.
And I think Celexa is a mirror, a molecule. It's the first one,
right.
citalopram. And Celexa is, if you're older, they take you off of that because it may cause heart issues. Is that correct?
Yes, that's correct. It could
And
prolong
Lexapro,
QT.
has fewer side effects.
Right. Mhm.
Yeah.
Yeah. So the Lexapro, I would say, is because it came out after Celexa, it's a little bit more superior. Maybe a baby step more. but yeah. So of course, Prozac was the first one. Do y'all remember when it came out?
It was like late 80s, wasn't it?
Yeah.
I remember it being. I was on the psychiatric ward as a chaplain at the Naval Hospital, and that's where they started prescribing it at that time.
So listen to this, Carrie. What do you think about this? This is a list of medication side effects. See how terrifying this is with people. But listen, don't turn me off listening public. You hear it all the way through. Here are side effects of a specific medication. I'm not telling you what medication is for a reason. Abdominal stomach pain, cramping or burning, blacks, tarry stools, bloody and cloudy urine, change in consciousness, chest pain or discomfort, confusion, constipation, convulsions, severe or continuing dark urine, increased frequency and amount of urine, diarrhea, difficulty breathing, drowsiness, fainting. Oh, I don't want fainting. Fast breathing, fast talking. I didn't add fast talking. I just add that because that was a joke. But fast breathing isn't. That's a side effect of, I can't tell you yet, feeling some terrible thing will happen. Fever, general tiredness, weakness, headaches, heartburn, increased thirst, indigestion, irregular heartbeat. I could go on. Do you want to know what these are side effects of? Coffee? No.
Yeah.
Neil's off the mic. He says, coffee? No, aspirin.
Aspirin.
Yeah, these are side effects
Well, it
of
would.
aspirin,
I mean,
John.
Yeah, definitely.
And I could have gone on
You
for a
take
lot
too much
longer.
of it causes bleeding.
Yeah.
Yeah.
So I'm not diminishing any of these that we talked about. It is terrifying, but I want to make the loud point, obviously, to you.
Aspirin would have
that-
been would be prescription if it were invented.
Well, right. I mean, there are prescription things, but I don't want you listening freaking out about side effects and medications. It's scary. It's terrifying. But when you know and understand,
They're the
and learn,
exception to the rule.
It's not terrifying.
Right.
It is
Right.
the exception.
If there is a problem, they black box it, don't they?
Yes. So with speaking of black box with the SSRIs and SNRIs, so antidepressants do have a black box warning for suicidal thoughts. So
We're jumping to that.
That is more specifically for children or people under the age of 23 or 24. So people whose frontal lobes have not fully developed yet. So, and the reason being is that if medications do the opposite effect, which would mean if somebody has depression and instead of it making it better, it makes it worse and they start to have dark thoughts or suicidal thoughts. As an adult, they know to get help. The impulse is not as much as it is for people under the age of 23 and 24. Though that age group, we go over that side effect very thoroughly because the parents need to know, the child needs to know, everybody needs to know that that's could potentially happen.
Is that you said it wasn't? I'm sorry.
Yeah, here's the thing. Let's stay with this a little bit, and I want to set this up a little bit because this is one of the, to think that you're taking an antidepressant that may cause, suicidal ideation is something that people get really confused about, and that's obviously terribly upsetting. But I want to go through this slowly for a moment and tell you, like, what I tell people, and I want to see if you subscribe or if it makes sense or if it's on point, because it isn't. I don't even see it as that it's been shown as being a side effect of taking Prozac or Paxil, isn't it? That's an SNRI, isn't it?
No, it's SSRI.
It is an SSRI. Okay, to taking Celexa or Paxil or Prozac. These are the medications for depression. I don't know that it's demonstrated that it causes suicidal ideation. Instead, what happens is you have the negative symptoms of depression where your energy's low.
You get more energy.
Your energy's low, your motivation's low, your stamina's low. And you also see the world as a sad place, a dark place, and you don't have hope and the different depression symptoms. When you start taking medication for depression, it helps with only some of the side effects immediately.
Right.
It gives you motivation and energy, John, as you say.
That you would have the ability to carry it out.
But you still have a horrible view that the world is such a dark place. So it isn't really a causal relationship. It's oftentimes I go to my medical prescriber, which is my family general practitioner, and they give me this medication and they say come back in 6 months, and you don't get any contact. You don't get any care. You don't get any psychoeducation that helps people understand what's going on.
Right.
And so ultimately you can have death from, but not from medication, death
Right.
from getting better, but only
Do
partially.
you hear the nuance that he's saying? I'm
Right.
saying that to the audience.
Right.
It's a nuance thing, but it's very true, I think.
And very important.
Would you agree with?
Yeah. How do you see all that?
Yeah, that's true.
How did we do?
Well, I think a lot of times with depression too is like people will let it go on and on and on and on before they get help. And that's one thing that really needs to change. It's like you don't want to let depression put you in such a dark hole that once you've come, you're looking for something. Unfortunately,
you're the last resort.
Right.
We in therapy also
Yeah.
are the last resort.
Brian Wilson, back in the 60s with Beach Boys, he stayed in bed for over a year because he was so depressed. And of
Yeah,
course, I think he had
brutal.
mood disorder as well. But
Right.
just absolutely confined and hopeless and helpless. And we don't want it to get that far, do we?
So
Right.
so it is fair to say, in your assessment, as you see the medications, that it's not a side effect of taking an SSRI. It is more some of the dynamics that go into our care as a profession to the person. Is that generally? Does that hold water?
yeah, because and what you were saying about, it helps to a certain degree, like with the energy and the motivation, and then people are more impulsive to actually do something. And those folks that have thoughts like that should be followed a lot. Like you said, they don't need to go 6 months without, seeing somebody.
Follow-up care in a
So-
month max. And if you have some self-harm thoughts and discussions, next week.
Right.
Yeah.
I was going to also, you treat, now I know you do motivational interviewing.
Yes,
And,
that's correct.
but you want to get to that, right?
Go ahead.
Okay. You use motivational interviewing. Do you use any other theories or
Therapy
other
modalities.
therapy modalities?
Yeah, like, do you do therapy still?
Yes, I do.
Yeah.
I have.
Coach John, she's a unicorn, man. Crazy.
Well, yeah.
I see a halo.
It's a halo. It's amazing.
I enjoy. I don't have many talk therapy patients, but I do. I think I have 5 right now, and I try to keep it minimal because I do focus on medication management the most. So, so I do have a handful of talk therapy, and I do have another handful of addiction. So with the addiction treatment, I do the motivational interviewing, and then I do just psychodynamic, person centered for talk therapy.
And I agree absolutely.
I feel like I'm in 1999, John. We've time warped back with a prescriber who does therapy. Like,
Yeah.
oh,
This is
it's awesome.
yeah.
It's totally awesome.
They give you 30 minutes that even in 99, but it used to be 45. I remember it used to be 50 minutes with a psychiatrist, and now it's certainly just collapsed. Question is, so you would say you would do the motivational interviewing primarily with substance use or alcohol use disorders?
Or any of the other. I have a lot of gambling patients as well.
Gambling process. Okay, good. Well, let me ask you this. When you get a combination of people, dual diagnosis, what do you normally treat first, or do you treat them both concurrently?
Yes, concurrently.
Oh,
That's
we'll
a good question.
We'll see how
Yes.
she does with traditional substance abuse counseling, John.
Yes.
Yeah, this is a trick question, Carrie.
Yes, concurrently. So I only for that part of it, for the addiction treatment, I get people into partial remission, at least 3 months, and then once they're at that point, I ask them if they're ready to start working on the things that brought them to the substance or whatever, and then that's when I find y'all, and y'all can take over the care.
Gotcha.
So that's, but in the, during that time also using medications, because there's so many better medication options now for treatment of substance use, any type of impulse control. There's something out there for it now.
Are you even doing like GLP-1s and things of that sort? Where
Not
you're dealing
yet.
with some of the addictive behaviors? Or?
Not yet. I would love to. So
Okay, well, first of all, John, you have to explain your question because I don't follow it, and I'm sure the listeners don't.
Well, in other words,
GLPMs,
it's
and
like
then
Ozempic.
follow up with what that is.
There has been recently a flurry of articles, of studies of using GLP-1s, which are what people take for Wegovy or Ozempic.
So these are the cool
And so-
commercials with cartoons
so,
on them.
Yeah.
Wegovy.
Kind
Oh
of
my God,
heavy
I'm so
set
tired
people
of these
dancing
commercials. I
and all
hate
that.
them.
But
Can I just say
using
that?
using them to reduce compulsive buying and spending, gambling, and I'm just thinking that's a whole area of practice that is out there. And they would actually need motivational interviewing. I think would do well with that.
And
as
before
well.
you respond, also, John,
And
you
gambling.
you can't geek out on all the therapy modalities. We did a show on that. We're done with
Okay.
that, John. You have to stay with
We
prescribing.
didn't even touch.
Yeah,
We
I
didn't
know.
even scratch the surface.
I'm sorry, man. We'll go back to that issue. But you're bringing up something interesting that I want you to respond to, Carrie. And I didn't realize this, but you and I created a thought not too long ago. Am I correct to say that Wegovy and those types of medications and whatnot are managing hormone production and influencing hormones
right.
and whatnot? Is that a correct statement, Carrie?
in the gut, yeah.
In the
so,
gut.
In the
so
gut.
everybody knows the gut brain connection.
Right,
And so
but
how,
hormones specifically
There
are
are
affected
more-
by those, right?
Yes.
Those,
John, do you remember our
apart from the brain itself, that has more neurons in it. doesn't
Okay,
it?
Yeah.
right. The brain, but do you remember our conversation? That I kind of wondered. We created at the same time that is this sort of strange experiences that we're seeing with menopause and other types of things related to hormones.
Right.
And I didn't know that Wegovy and these HP, what did you call them?
GLP.
GLP-1
medications
Right.
that are used for weight loss and weight management and whatnot are being prescribed off-label? Question mark.
They're doing a
for
lot of research
compulsions?
because these things have only been out for 4 or 5 years now.
So what are the impacts on compulsions?
It helps. It's amazing. It's not really Ozempic. I haven't seen that much. I mean, Ozempic can be
another
helpful.
one.
It's the other one. It's tirzepatide. So the
Tirzepatide.
Zepbound,
I can't pronounce it.
Monjaro, those.
Right.
We'll
those
just let
two.
Carrie pronounce it, John.
So those medications have been very beneficial. I've had quite a few
Really?
people stop drinking alcohol with them, and I can't prescribe those myself, but I do a ton of education because I want people to know that I want them to choose that one over the other.
Why can't you prescribe them?
Okay, so I'm not family practice, and I did not do that side of things, so I don't do the medical side. However, if it's a side effect of a medicine, then I can't. So back to the Viagra. If it's a side effect of a medicine and it's a medical medication, then I can do it related to the side effect. But that hasn't really been signed
That's
off
almost
yet.
like how VA does things, which is not very well in that area. I think there should be a broader. See, I'm trying to bring you more business.
All right, yeah. Let's get back
Thank
on
you, I appreciate
to
that.
yeah. We could go for hours with that. I mean, that's a deep hole that I want to pull us out.
Well,
of. And I want to move to before we run out of time. Some of the current events, some of the things that's kind of going on now. So we said we'd get political a little bit. There's two main areas that I kind of want to go into because we've already talked about the self-harm and the suicide thing, and I know that's in the public eye and a big concern and how that works with medications. So there's two areas that I want to get your thoughts about, Carrie. One is just the newer medications. Like I'm curious about what generation of drug we're on. Like I know third generation, some of these fourth generation are going to be familiar to me, but I know we start getting into fifth and sixth. I'm starting to get lost with the new medications. Like and I don't like that. So I want to ask. We probably need a whole nother show for that. But the other is the Bobby Kennedy's claims and concerns, specifically with SSRIs and what you're seeing with patients that are coming in with these fears. I mean, hopefully we've addressed a little bit of this already, but those are two areas that I want to go into.
Yeah. Well, with the politics and things, we've tried so hard. All of us, therapists and everybody in the mental health field has tried so hard to keep, help the mental health stigma. And now the politics it's really almost tearing down the things that we worked so hard to get to. And to the point where I've had some primary care doctors who won't now start medication. They are sending people who need antidepressants to mental health providers. I don't know why. I don't know.
Wait a minute. Say that again.
I've had doctors that would not start antidepressants. Like usually when you have depression or anxiety, you'll get screened. They ask you one or two questions at the doctor's office. And then typically a general practitioner or a PCP, a primary care physician, will start an antidepressant because they back in the day they used to do everything, right? Now I've seen recently, this has just been within the past couple months, patients have come to me and their doctor would not start them on.
Really?
And I was shocked, and I don't know if it has to do with these changes that have been going
fears
on.
And stuff.
Well, or even
HHS, I should say. Sorry,
I think maybe the healthcare providers are probably scared that there might be a lawsuit down the road somewhere down the road.
I hope that's not.
But
happening.
I think part of it has been the scaremongering of certain politicians, and that don't have any particular education. They're a lot of times they're lawyers, and I love lawyers, but they need to stay in their lane and
practice law.
Practice law,
not medicine. Yeah. So, Carrie, how much are you hearing this from people? Like, what's happening in your practice with the? I mean, I'm going to imagine you might even have people that are already prescribed and working with you, and now come in with new fears, hearing things. Are you even seeing that level?
Not yet, because I think that the people that have already been working
You've educated
with
them.
Yeah, they know, and they know the difference too, because I tell them what to expect, and how things are supposed to be, and things like that. And we always keep, and they know that they can contact me anytime, and they know to contact me by email, because that's the best way to get me. So there's always that open communication, and I don't want anybody to have any fears about things. When it comes to medications and things like that, because they can be so helpful, but I want them to be educated enough to be able to make a great decision for themselves.
So, yeah, I don't know how. Through a Therapist's Eyes is here to blow up stereotypes, myths about mental health and substance abuse, and then disseminate as much information as we can about these topics and things. And I guess I'm not sure about how big and wide this net goes, that people are fearful. I actually thought that there would be people developing new fears, even though they're educated, because you hear so much, and there is fear mongering, John, scary kind of reports, and the suicide thing is just terrifying for sure. Like, it's a lot of.
That's been an issue for 20 years, though.
Yeah, right. That exactly. And so I guess I'm wondering, like, how big of an issue this has come, or is this chasing a red herring that people aren't having new fears about this? I don't know.
Well, I know that one other drug that there's a lot of
Being targeted.
Yes, being
Adderall?
targeted. No, not Adderall.
Oh, well, we got another one too.
Suboxone. Suboxone is one of the absolute best medications to help with opiate use disorder, whether somebody is addicted to heroin, fentanyl, opiate pills. It doesn't matter what. Now, kratom. Hate to say that, but
It's a thing.
people don't even know what that is. But
Kratom is
it is a
another,
thing.
Another
Avoid it.
derivative of opioid.
Yeah.
It's
So
in the same
a
family.
lot of people.
And you can get it in stores.
Yeah.
now,
Can.
around North
I kn-
Carolina anyway.
I knew
Right.
an officer, a police officer, that was using it because it wasn't being tested.
Mm-hmm.
So,
Right.
but
Yeah.
it has a lot of side effects.
Oh yes, it does. And so Suboxone is there's not enough education about how wonderful that medicine is to help people with cravings, help people with withdrawal. The two biggest reasons why people use and can't stop on their own is cravings and withdrawal. If they get sick, they need something. They don't want to be sick. And it's very hard to go through that all the time, use and then start withdrawing. And that's why the pattern continues. And families will say, if sometimes I've heard patients will come for treatment with Suboxone, and the families will say, "Oh, you're just trading one drug for another." Absolutely not. You are trading an illegal substance for a substance that is legal and going to keep you off the streets and off from buying things that you shouldn't be buying or getting you in trouble with the law.
Do you use a Vivitrol?
Yes, naltrexone and Vivitrol use that a lot too.
So, Vivitrol goes into the butt, doesn't it?
Yep.
Basically.
Once a month.
Oh, wait a minute. Wait a minute. We just turned south.
Because I have some clients that are on that and have had great experience with that. What is your opinion of that?
I think it's great. I think it keeps the levels.
So Vivitrol is what, John? And we use it for what? So
naltrexone is for alcohol use disorder. It could also be opiates, right?
Mm-hmm. It's for opiate or alcohol.
It's another one of the same types of things as methadone, or Suboxone.
The only difference between them is that it's not a controlled medication. So it helps with cravings. It helps for people. So say somebody
just basically these are substance abuse treatment medication world. We just switched to that different domain.
Yeah. So for people who have been able to stop on their own, but they're still kind of struggling and still kind of having periodic cravings and things like that. Naltrexone and Vivitrol is wonderful because you only have to be 7 to 10 days free of alcohol or opiates to start it, and the dose for the tablet, which is the naltrexone, is just once a day, and there's no increasing that. It's just one pill, 50 milligrams once a day. I do have some people I have to take a half tablet if they have side effects, but it's still a better option. It can also help with food related. So I don't know if everybody's heard of Contrave, but Wellbutrin, Wellbutrin and naltrexone's in Contrave, so that helps with food cravings and issues with that.
Wellbutrin is used for smoking cessation.
Yes, and I use a lot of Wellbutrin.
So really, personally or professionally? Sorry, that just hit me. The way you said that, I was like, "What do you mean? You use a lot of Wellbutrin?" Well, I use a lot of Adderall. How about that?
I have my favorite medications that I like to prescribe.
Now I lost my train of thought. I had a thought that
you need some Concerta or
exactly.
Vyvanse.
Vyvanse. That's it.
People have said I have
a
touch
Vyvanse?
of AD.
Yes, Vyvanse
ADHD, but I think it's a learning disability that I have, not ADHD. But that's a whole nother. Topic.
Well, I can give you an assessment.
I am curious. No, John, I'm not taking your test, John. I'm getting you. We're not going backwards to the surveys and everything. But I am kind of curious, real quick, because we're needing to wrap up time wise. What our generation of drugs we're on now at this point? I mean, we've had different iterations of medications that have improved over the years. First generation just means like an old medication that we used to use that now we don't. Like trazodone is a first generation medication, antidepressant, I believe. That now we don't use for anything but like a mild sleep agent. Right. So generation 3, 4, 5, we up to 6, 7. Where are we at?
Well, that's more for the antipsychotics. So that's specifically for first generation antipsychotics like Haldol, and then second generation like Seroquel and Zyprexa, Risperdal.
And that's been a lot of the weight gain issues that come with that.
Second's where that goes.
But the newer generations seem to be less.
Yes. So any medicine after Abilify or starting with Abilify and after are supposed to be better as far as weight gain goes, or increased appetite and
emphasizing
weight gain.
The word supposed to.
Supposed to be, but we still know, and I still tell people, and with those medications, dependent upon if they have to have it. So, with some diagnoses, you have to take your medicine. Bipolar disorder, schizophrenia, you have to take your medicine regardless of if there's weight gain, which is good that the GLP-1s came out, because now the weight gain can be managed with the GLP-1. So it's good now. But yes, Abilify and on's not supposed to cause as much weight gain, but it's still possible.
So I told you we would not be able to cover everything that we wanted to cover, because I have like a lot of questions in my mind as well that I know people would have. But John, I want to make sure you have space to. Did you have other things that we're wrapping up with?
I just want her to come back.
Probably will. Yeah, if we can give answers.
Sure.
I just want her to come back. I want her to come back too, John. Do you think she will? Maybe. Because there's a lot of questions about people are curious, like, is this going to be the rest of my life? Can I take these for a season of my life?
Right.
Are there some of these medications that I can take what's called PRN just when I need them, or do I have to take them every day? And the answer is
Individualized treatment.
Okay. Bufar,
Right.
for example.
there are some things that we can know with the type of medications, though. But
Right.
generally speaking, yeah, you have all of those kind of options. But I just don't want the public. I don't want you to be fearful of like, oh my God, if I go there, they're going to tell me my life is different, my life is over, and until the rest of my life I have to take this pill, and I don't want to do that. That's not the way that it works. Fair.
Right. Exactly.
Right.
And any time that we come off a medication, I always, still follow. It's just because they stop the medicine doesn't mean that I don't see them, because I'll follow up with them in about 4 or 6 weeks after they've
Good.
stopped the medicine. Well, and plus usually there's a taper, so we'll make sure that the taper is going okay, because some meds can be hard to come off of, and some you can cold turkey and it's fine. But so with I see them to be sure, because if you've built up that serotonin from an antidepressant and then you take it away, that serotonin buildup's going to go away after 4 to 6 weeks, and then you're going to see what your serotonin's doing. So that's when you need to start looking for any mood changes and for any, depression kicking back in or anxiety.
And so you work with people coming off of medications as well as starting them.
Yeah,
correct?
I will. If somebody wants to, they call it de-prescribing. So if you want to come off, we can do that as well.
Great.
Then
Yeah.
you could
Right.
actually, somebody, let's say you're having a treatment for a medical conditioning requiring steroids, for example, that can affect one's mood very
yes.
definitely.
Prednisone.
And prednisone, yes. Besides the
good
puffing
stuff, though.
face, yes, this, yeah.
It's good stuff as long as you don't hallucinate on it.
Yeah,
Yeah.
it's good stuff, though.
Yeah.
So I mean, yeah. So I think it's essential that. So you are someone that will basically have a bit more familiarity, and this is not to diss a primary care provider, but it's that you would be able to give a lot more specified treatment and perhaps more in-depth treatment. Of course, we need the psychiatrist, we need the psychologist, but I think the problem is there's not enough time. Bookings are like 6 months
Yeah,
to
absolutely.
see somebody. It's in great crisis and distress.
Perfect transition, John. So where do they find you again? Let's make sure that they got the thing. And I want to make sure that, on our website, throughatherapisteyes.com, we're going to have the links that you can click on and find her real easy. But where do they find you again?
Yeah, so they can come to my website at www.roadtrip2recovery, the 2 is a 2, number 2, .com, or look me up, Carrie Hill, just Google search in Belmont, and
You
it
can't
should
just say
pop up.
Carrie because we already established it'll be Underwood. So that's
Carrie
not you.
Hill. That's my name's
I
very
Googled
small,
it.
so it's easy to remember.
Right. And so we'll have all that up there and have people be able to find you, because and I mean this seriously as a compliment, and I think you hear some of John's reactions. I mean I don't know if you know how cool it is that you're doing what you're doing, because it is very refreshing to have a prescriber, and if you're in the local area or one of these 18 states, 18 or 13?
18.
18. See, I told you my learning disability. 13, 18, 12, 20, what did she say?
So
really
a third
that,
of the states. at
that
least.
being able to find somebody like yourself that is going to spend time, that's going to be thorough, that's going to answer questions, that's going to respond and be responsive, like you're not a part of a medical group. Like, this is great care for your psychiatric medicine needs, really.
I try to do the best I can because I want everybody to live their best life, and that's in one of my videos too on Psychology Today. But I really do. I mean, we're here, we don't know
And
how long we got.
And lastly, you have a blog.
Yeah.
Tell us about the
Yeah.
blog real quick.
Oh, I've got a couple things, but there are a couple articles on there about what to expect in a first evaluation, because like the screeners that we
Yeah,
were
but where do
talking
they find
about on the website.
On your website.
On the website, yeah.
Yeah, so we need screeners.
John. You can do your screeners, man. Nobody said you can't do screeners. Screeners are fine. I have no problem with screeners, but you do screeners. I'm not doing screeners. Carrie does screeners. Great.
Okay.
That was awesome. All right, you got any other thoughts or whatnot?
No.
Okay, Carrie, do you have any summary points or thoughts and things that you'd really like us to remember or keep track of?
Well, I just want to, tell people don't wait till it's too late to get help. If you see a family member, if you see a friend, if you see somebody struggling, encourage them, because if they are having depression and anxiety and you feel like they need to get help, sometimes people can be stubborn, but you just have to, be with them and try to help them the best you can. And if you, reach out to me anytime if you have any questions also about family, because a lot of times family don't know what to do for other family members, and you can't help somebody who doesn't want to be helped. However, you can have a conversation with
And you got a phone number?
So I do, but
Oh,
the website
email.
is-
You said
yeah,
email
email.
is way better.
So you can email me at carriehillnp@roadtriptorecovery.com.
Carrie Hill NP at roadtrip2 with a 2, not a TWO, recovery.com. Got it.
Excellent.
All right.
That's good, because now people are going to remember this. They're going to visualize it.
I mean, I think so.
Yeah.
So we end up the show with doing a shrink rack up, is what we call it, John. The shrink wrap up. I said rack up. I meant wrap up. This is where the panel gives their thoughts, their takeaways, in a little short description. We can describe things, Neil. I mean, it doesn't have to be short and sweet like last week. I think we got ramrodded there a little bit, John, last week. Neil just picked Victoria. I don't think that was really. I think that was really rather impulsive.
I think I would be very surprised that either one of us would be picked.
Why would that be? Because Carrie's better than anything we've ever.
She's already wrapped it up well.
I know she's awesome, but we can still try.
Okay.
All right, so that was hers. John, what's your shrink rack up? Wrap up. Jeez.
I think it's essential to have an open mind about receiving psychopharmacology, or to have these medications. I think they're very special. I think it's something that people should be open to and would be able to work in conjunction with psychotherapy, because it will work quicker if you use both of these modalities together.
All right. I see that Neil's already beat us to the punch. Neil, did you get those states?
Most of them, I think.
Looked them up. He looked them up and he's got them, so it's already in the show notes for you. All right, my wrap up is that hopefully we have addressed some of the concerns, because, as I've said many times over, medications are a wonderful tool in 2025 that we now have technology for, and so please take advantage of that. Though knowing it's not a solution. Really, therapy and medication management in combination is what serves the best results, and we've got that well-researched and well-studied. But I don't want people to have the fear. So hopefully you've heard some of our talk about don't be fearful, be aware, and people and providers like Carrie that are going to talk to you are going to give you information so that they'll help you along the way. So, Neil, how'd we do? Who'd won?
Actually, those were all really good wrap-ups, but I have to give it to the expert. Carrie's got to have this one.
Thank you.
Now,
Thank
Neil, if you would treat me like that normally,
I
that
know,
would be
right?
wonderful.
Right? Same. I feel the same way, particularly last week. Last week we got gypped, Carrie.
It was me, wasn't it?
All right. It has been a pleasure having you, ma'am. We definitely want you to come back, I think, because there are things that we talk about that, we need a medication prescriber's angle on, and we hope that happens.
Yeah, I would love to come back. Thank you for having me today. I appreciate it.
All right. Listen, you guys take care, stay well, and we will see you next week.